I feel like I could talk about this stuff in my sleep at this point. I've been working with Dr. Kirkwood since 2005, which seems like an unreasonably, I can't be that old, but I guess I grew up in the Melanoma Center. I also recently, as Sam had said, took on the role of being the Ask a Melanoma expert on their Aim at Melanoma website. And a lot of the questions that I get are general questions, but a lot of them have to do with side effects of these checkpoint inhibitors. I literally could talk about this topic for the entire symposium time. So because unfortunately, the inflammatory effects and the autoimmune effects that these drugs tend to cause can happen in every single organ system, straight down to nerves and encephalitis and skin. So in the interest of time, I'm gonna really just talk about the big ones, the ones that most commonly happen. If you have questions about other ones or I didn't address your specific thing that happened to you, you can always ask at one of my many places that you can get a hold of me. The ones that we're going to talk about are the anti-Pdl One antibodies. Those two are basically pembrolizumab or Keytruda. You're going to hear me refer to this as Pembro. And then nivolumab or Opdivo, and you're going to hear me refer to this as Nivo. The CTLA-4 antibody is actually ipilimumab. There was another one, but we don't really use it anymore. Ipilimumab is also referred to as Yervoy, but I in this lecture will probably refer to it as Ipi. And then you have the Pdl One antibodies, and these are actually ones that are being used in clinical trials still. I wanted to mention them just because they exist, and you'll probably hear your oncologist or someone talking about them, but these are not going to be really addressed in my lecture today. So how do these things work? The anti-CTLA-4 drugs, Ipi, works by taking the brakes off of your immune system. So you just have all these T cells, which are the fighter cells. They're basically responsible for attacking all the things that don't belong in your immune system. So in the interest of making these, great, they're attacking hopefully your melanoma, but sometimes they start to attack normal tissues as well. PD-1 inhibitors are sort of like unmasking cancer cells. The really tricky and unfortunate thing about cancer cells is that they're made by you. They just lack the things that make them normal. So normally when cancer cells grow, they touch, they stop growing, or normal cells. Cancer cells, when they grow, they touch, and then they start to clump. They forget how to stop. And so a lot of times, because they're made by you, your immune system doesn't really know that they don't belong there, and they just ignore them. So part of one of the things that the PD-1 inhibitors are trying to do is actually help your immune system recognize these things as foreign. So it's a good thing. But sometimes when you activate the immune system in these ways, they become overzealous. They attack not only cancer cells, but also normal cells. And these things are what Amy and Darcy and Ashley and now I are mentioning, which are immune-related adverse events, or IRAEs. How often do these occur? They can either occur 15% of the time or pretty much all the time. A lot of the higher recognition of these IRAs is because we're getting more aware of them. Like when we very first started to use CTLA-4, we didn't even know what hepatitis was. We never identified pituitary dysfunction, and then all of a sudden we started to, and then we became very much more aware of this. And sometimes, like, Ashley and I will be sitting in clinic talking about someone and we're like, I just have this feeling that there's something wrong with their pituitary. I just feel it, or like they're adrenally insufficient. I just feel like they have that. And there may not be a specific reason. And so a lot of times these higher than normal adverse events are because people like us are really thinking about your complaints whenever you're not there. We do see that Ipi at a higher dose has a higher rate of toxicity than at the lower dose. We do not see the same type of thing with the PD-1 inhibitors. For example, like using nivolumab at the 240 milligram dose every 2 weeks doesn't seem to have a different incidence of adverse events with using the higher dose but less frequently. About 13-ish% of patients will develop adverse events that require us to put them on steroids. A lot of the people that I see in this room actually have experienced that. That would require us to even maybe remove them from treatment. Okay, so here's where the ones in red are the ones that I'm going to really focus on because those are the most common, but as you can see from the other column, really These drugs can affect any organ system. Fatigue tends to be one that is present in a lot of these, in a lot of patients. It's also the most difficult to treat. Unfortunately, unlike the BRAF inhibitors, once we take the drug away, once these adverse events kind of start to be in motion, we're kind of on the ride. It's a roller coaster that you can't really get off until it either runs its course or the interventions that we use make some type of meaningful change. Darcy went over this a little bit, but this is the very simplified version of how we grade your IRAE. If it's and this is more for like a standard of care setting. It's grade 1, it's very mild, it's not really affecting you. It starts to become a little more of an issue, or we may start to give you some like over-the-counter things. That's when it becomes grade 2. If it starts to become pretty significant, but it's not life-threatening, it would be grade 3. At this point, we're probably thinking about or have already started steroids. If we see grade 4 toxicities, you're probably in the hospital getting IV steroids or some type of immunomodulator. And obviously, we don't ever want to talk about grade 5 because that means that something that we did to treat your melanoma actually caused death. Okay, so dermatologic adverse effects. Sometimes you'll have a rash that is itchy. Sometimes you'll just have a rash that isn't itchy. You can also develop, and I actually have a picture in the next slide, but sometimes you can develop vitiligo, which is an autoimmune response to the melanin in your skin. Sometimes it can just be a side effect of the drug itself. Other times it can actually be that your immune system is attacking melanin cells, which is good because your melanoma is made of melanin. You can develop a very severe skin toxicity called Stevens-Johnson syndrome or epidermal necrosis. And this is where like you start to see like blistering of the skin where the dermis and epidermis separate from one another. It can be a very life-threatening condition if it's not treated appropriately. It's almost like being a burn victim, and that's exactly how it is treated. There's various presentations of rash. Here, whoops, these are some of them. These aren't any of our patients. I actually stole these from the internet. But you can see like they can range from patch or plaque-like rashes that almost kind of similar to psoriasis. They can be fungal appearing. They can actually look like hives. The dermatitis can be anywhere from like a tiny little patch on your skin to your entire body, the inside of your mouth, on your eyelids, on vaginal surfaces. It can pretty much go everywhere. We actually used this sort of guide to help us determine how much of your body surface area is involved. And this in specific for dermatologic AEs, there are some toxicities that the grading is a little bit arbitrary based upon who's doing the grading, but this is pretty straightforward as far as surface area. Usually for mild toxicities like grade 1 and 2, we're using antihistamines like Zyrtec or Claritin, Benadryl, topical Benadryl. We may use topical steroids for this. Once topical steroids would need to be applied to your entire body, we kind of lose that, so we start to do oral steroids, or you may even be admitted for IV steroids as well. So vitiligo, or that depigmentation of the skin, there's a very good picture of that. Most people will notice it more in the summertime or when they've been exposed to UV light, and the reason for that is that the actual non-affected areas will become darker, which accentuates the areas that are lighter. And then the picture on the right is poiliosis, which is actually vitiligo of the hair follicles. So you actually see the depigmentation, but of hair, and you can get it of the eyebrows, the eyelashes, the hair on the head as well. We've actually had a couple people where like eyebrows, eyelashes, and their whole head of hair is completely white. Okay, enterocolitis. Well, this is the one that all the people dread when they read the side effects of drug, of either Ipi, Pembro, or Nivo. And it's diarrhea. So we are very, very diligent about trying to establish what a patient's baseline is, because if you already are starting out going 3 or 4 times a day, it wouldn't really be applicable that you're having, you know, a grade 1 diarrhea if you go one more extra time. So establishing baseline of how many times a day you go is very, very important. But not everyone that has colitis will just have diarrhea. So sometimes patients will present with just abdominal discomfort or cramping. We've actually seen and most of the colitis happens in the descending colon, which is what would cause the diarrhea, but we've sometimes seen ascending colon or more proximal diarrhea, colitis. And that actually will manifest more as nausea. So if someone is having like extraordinarily difficult time eating or nauseous all the time after they eat, we really have to consider that they may have an atypical colitis that is affecting the opposite side of their colon. Anytime that someone would have mucus or blood in their stool, we consider that a pretty significant sign, and we're probably sending most of those people to the ER. Peritoneal signs are like when your stomach hurts when you're like running over bumps, or if you're walking and it hurts worse. That means that the actual lining of the intestines is inflamed. That can sometimes be a pretty big emergency because that's also a sign that you may have perforated your bowel. That's no good for business. So one of the things that makes it tough is when someone calls and they say, I've been having diarrhea, but it's only like 2 or 3 times, but it's been for like 2 months and I haven't called anybody. We get really worried about those patients that are on Pembro, Nivo, and Ipi because we now know that chronic colitis is just as bad as having a severe event, because you can also have a perforation and have pretty severe ulceration of the bowel from just this chronic low-grade inflammation over time. And some of those patients are actually really difficult to treat. So the take-home message from that is, if you're having any of these symptoms, really you need to call us and let us drive the boat and try to make it all better. And you may not want to go on steroids, you may not want to have to go to the hospital, but in the end, we're doing this to help. So this is what colitis actually looks like on a colonoscopy. I'm a very visual person. I think it's really cool to see these kinds of things because like when we're explaining to you like, oh, you have an ulcer in your colon, what does that look like? Here it is. So little white patches represent areas of inflammation. Again, these are seemingly very superficial ulcerations, but they can become very deep and actually can put a hole in your bowel. And then all that stool that's supposed to stay in this nice little contained environment is now in your abdominal cavity, which can cause pretty bad infections. Okay, hepatitis. This actually is one of the side effects that happens in about 5-ish to 8% of patients. We actually typically find these side effects prior to the patient having complaints because we're drawing labs so frequently. But some side effects, if you were to not be picked up on labs, would be not wanting to eat, kind of a vague right upper quadrant abdominal pain. You might feel queasy. Hopefully you're not jaundiced. That would mean that you're yellow, but that can sometimes happen. You may notice that your urine is very, very dark. But again, the liver functions in these instances are almost always elevated. If we have grade 1 and 2 elevations, which are only slightly elevated, we would monitor the liver functions pretty closely, like get labs every couple days. We may start oral steroids to try to control it. For grade 3 and 4 hepatitis, we often see these liver functions like 3 and 4 and 5 and 6 and 8 times the upper limit of normal. We'll actually start IV steroids. And if those don't actually bring them down in a timely manner, we will sometimes start things that are used for anti-rejection or immunomodulators like Cellcept or tacrolimus, which is actually a drug that's more often used in anti-rejection for organ transplants. Okay, pneumonitis. This is something that we're actually picking up more and more. We're seeing some delayed pneumonitis in patients where they may initially not have symptoms, but the later in treatment they develop things like dry cough, wheezing, and unreasonable shortness of breath. Like I got up from the couch to go get a drink of water and I needed to lie down in the kitchen because I was so short of breath, or like not being able to converse with someone without seeming like they're having a hard time breathing. A lot of times we'll pick that up in clinical exam. Be in a room with a patient, they're just really like huffing and puffing, but otherwise are asymptomatic. A lot of times that'll lead us to investigate pneumonitis. So what that literally means is inflammation of the lung. it can sometimes in very severe cases cause your oxygen saturation, which is how much oxygen you're actually able to perfuse across the lung, to go down really, really low. This is like my biggest fear as a person, because I get so nervous about not being able to breathe. So I may act unreasonably if you come in with shortness of breath, and that's why. We usually, most of the cutoffs for discontinuation of drug are grade 3 and 4, but this one is grade 2, because we oftentimes see that this can be a very, very severe toxicity. We'll sometimes hold treatment for 2 to 3 weeks if we think that it's a mild issue. We may put you on an inhaled steroid, sometimes albuterol. But if we start to get in the grade 2 range, or we see pretty significant signs on CT or chest x-ray, we'll oftentimes start oral and IV steroids pretty early in symptomatic management. One of the benefits of having used these drugs over 15 years is that we're learning things every day. So last year, we started using a drug called tocilizumab, which is an IV medication that blocks one of the interleukins that you give just once a month. And we've seen remarkable decreases in pneumonitis without a significant decrease in the, without making a patient really immunosuppressed. We use it most of the time at this point with refractory patients that just have pneumonitis that doesn't respond well to steroids, or that you get them all the way off the taper and then the pneumonitis comes back. We'll oftentimes use drugs like tocilizumab, sometimes infliximab, but I really like tocilizumab. It seems to work really, really well. We've had 3 or 4 cases where we've had to use it, and it's been really effective. This is what pneumonitis looks like on your chest x-ray and CTs. So I'm afraid to walk away from here because I don't want to leave if they're taking video, but these are all the areas of pneumonitis, all the white spots, and it's significant inflammation, and it's more patchy here. But all of those places where it's white, you can't perfuse oxygen. So it's obviously, I'm sorry, I won't. Oh, I can use a mouse? Yay, okay. So, see, I'm not technologically savvy. So all of these little spaces, you can't perfuse oxygen. So you could imagine that it would be pretty difficult to breathe. This patient actually has a ton of issues with shortness of breath and cough. The more central, I'm gonna go back real quick. The more central that the inflammation tends to be, near the main bronchioles, the more people are symptomatic. So usually when you get pneumonitis really far in the outside of the lung, it doesn't tend to have as many symptoms. The other thing that can happen in the lung is a sarcoid-like reaction, where it's almost like an autoimmune infiltrate that occurs that causes pretty bulky lymph nodes in the central part of the chest, and that's what these little clumps here. We've actually been fooled a couple times where we thought that there was disease progression, but upon biopsy, we found that these were sarcoid. So that's one of the things that we now have to keep in mind, especially when we see new lymph nodes that are centralized in the chest. You sometimes can get this sort of train track appearance where it sort of comes around a smaller bronchiole and makes it look hard, and that's basically what sarcoidosis is doing. It's hardening the tissue there. Okay. Hopefully I haven't lost everyone so far. And then there's the endocrine side effects, and this could be its own lecture. This is where we're looking at the glands. So the thyroid may work too well or not well enough. You may develop adrenal insufficiency. Most of these patients are really, really tired. Their blood pressure's low. Can cause pretty significant nausea and vomiting. It actually also can contribute to diarrhea. So this is something that I always keep in the back of my mind for patients that are complaining of those vague sort of symptoms. Here's where hypophysitis comes in. That's the pituitary gland becoming inflamed. The pituitary is actually responsible for all of the signals for the thyroid, for the adrenals, for the testicles, for the ovaries. And so when your pituitary goes bad, we have to check all the endocrine function because it's kind of the mastermind of all of your hormones in the body. We actually had a question on a piece of paper that I left over there about type 1 diabetes. We didn't really know that this was a significant side effect until a few years ago. We actually, in the probably last 5 years have had like 3 cases of this that I'm aware of. The way that we sort of monitor this is to just kind of look at glucoses as you come in for your treatments. We have done hemoglobin A1Cs. We have done more specialized beta testing. We'll oftentimes refer to endocrine for these types of issues. But type 1 diabetes is a very significant side effect that we are just now kind of becoming aware is more of a problem than we had originally thought. As I mentioned earlier, you can have low testosterone from this. A lot of times the endocrine side effects are very vague. Like, I don't feel good, I might be a little more confused, they might be hypotensive, they might have no interest in sex, they might have gained weight. So these kinds of things are, like if someone comes in with really vague symptoms, this is what we're looking for. A lot of times these are diagnosed by labs. The neurologic adverse events, there's a plethora of neurologic things that can happen. It can be numbness and tingling, it can be paralysis. I listed some of the main ones that are associated with the Pdl One inhibitors and with CTLA4. We've since consulted neurology on a lot of these. It depends on the symptom or the syndrome, how you treat it, but a lot of times steroids are used. Cytokine release syndrome is one of the only things that can happen while you're getting the drug. It's sort of like, as Darcy would probably refer to it, as a reaction. You'll get flushed, you'll get feverish, you'll get short of breath, sometimes the blood pressure will drop. Hopefully we get it before you start vomiting and have diarrhea. But really this is the supportive thing. We stop the drug as it's being infused. We give Tylenol or ibuprofen, sometimes Demerol if you've got the shakes, oxygen if you're having trouble breathing, IV fluids, and then we kind of treat like, are you nauseous? Have some Zofran. If it persists and we're not really able to get a good grasp on how it's going, we'll sometimes use corticosteroids like Solumedrol or hydrocortisone. Especially if like the blood pressure doesn't really fix itself, we'll admit patients, keep them on IV fluids. And this is another place where tocilizumab is generally very nice to use here. Okay, when you have to go on steroids, this is like one of my most important things that I'm going to say in this lecture. When you go on steroids, it does not appear to affect the response to immunotherapy. So we've got this train, it's going 60 miles an hour, things are flying out the windows, we can't control this. What the steroids are doing is trying to get the train back to a normal speed where we're not out of control, things aren't flying around the cabin. You're still having an immune response, we just need it to be a little bit more contained so it's not out of whack. So just remember that even though we put you on steroids, it doesn't mean that your treatment's not working. Okay, all done.